Okay, so in today's session for midwifery, we are looking at the third stage of labor. So we'll go straight into the lesson for today. So before we look at in details the management of third stage of labor, remember we have looked at management of the first stage of labor, then we we're looking at the management of the third stage of labor. So if you have never gone through those sessions, be sure to go through the sessions posted previously for first stage and second stage, as well as for normal labor. So now, how can we define third stage of labor? We can define the third stage of labor as this is the period from delivery of the baby up to the delivery of the placenta, which usually takes about 30 minutes on average, which is actively managed in order to prevent postpartum hemorrhage. So that is how we can define third stage of labor. So now you'll find that on average, yes, we understand about 15 minutes or so, the placenta needs to come out. But the standard is that it can even take up to 30 minutes after the baby is out. And this is actively managed, meaning you are, of course, giving oxytocin so that the placenta can come out. And this is done so that we prevent postpartum hemorrhage, because if the placenta is not out, meaning this woman may continue bleeding even after the baby is born. And then apart from that, what other area can we need to know? We need to understand what is the puerperium. So how can we define puerperium as well? When it comes to puerperium, this is defined as the period from the completion of delivery, meaning end stage or the end of third stage of labor. So that is what we mean by completion of delivery, to the end stage or the end of 6 weeks postpartum, during which time the woman's body returns to normal. So when we talk about normal puerperium here, we are talking about the period from the time the placenta is successfully delivered or completion of the third stage of labor up to about 6 postpartum weeks. And this puerperial period, this is when involution also takes place, where the uterus and every part of the woman body remains or goes back to its normal structure or physiological structure. Because everything else needs to return to normal rather after the baby is born. Then apart from that, we need to understand some of the methods of placenta separation. Remember, the methods of placenta separation are different from the signs of placenta separation. When we talk of signs of placenta separation, probably we are talking about maybe elongation of the cord, because the umbilical cord becomes longer after the placenta separates from the walls of the uterus than the normal length that it had after cutting it. Apart from that, you may actually see also just gushing of blood, just enough blood, like blood clots, come out of the birth canal at just the same time in some high quantities, and then it does not continue. It's different from active bleeding, where you see bright red blood continuously coming out. Apart from that, you may actually see just presentation of the placenta itself on the vulva. So those are signs, some of the signs of placenta separation, but here we're talking about the methods through which the placenta separation through which the placenta. Talk about the Schuss method. We are talking about placenta methods of placental separation, which is SCHUTZ. So Schuss method, this is the method where the fetal surface of the placenta appears first on the vulva with membranes trailing behind. So in this particular type, you'll find that the placenta separates in the center and folds itself as it descends into the lower part of the uterus. And also the retroplacental clot is contained within the membranes as the membranes are coming out, or as the placenta is coming out. So in simple terms, the Schuss method is where the fetal surface or the fetal site of the placenta is the one which is presenting on the vulva. The other method of placenta separation is what is termed as the Matthews-Duncan method. So when it comes to the Matthews-Duncan method, this is the method where the maternal surface appears first at the vulva. And in this method, the placental separation starts at the lower edge of the placentolateral border sides. And it is usually accompanied by more bleeding from the placental side due to lower separation, and there is no placental vision. So when it comes to the Matthews-Duncan method, it's just the opposite of the Shoes method. The Shoes method, you're able to see the fetal site presenting on the vulva. Then the Matthews-Duncan method, you're able to see the maternal site presenting. So those are some of the method of placental separation. Okay, then apart from that, now we can go into details and look at the management itself of third stage of labor. So as usual, when we are looking at the management of third stage of labor, or any management rather, we need to start with the at least aims or objectives. So in this particular case, we can say to ensure that there's complete delivery of membranes. Apart from that, we can say to assist the woman to deliver the placenta. You can also say to control bleeding vaginally. The other aim, you can say to prevent complications such as postpartum hemorrhage. Once you have 4 aims or objectives, the next heading that you're supposed to have is psychological care. So on this particular heading, you can say, I will tell the client that she has delivered successfully. She has delivered successfully the baby, and she needs now to deliver the placenta so as to promote cooperation. So when you explain this woman will now be cooperative, because she now knows to say the next thing that needs to come out is the placenta, since the baby is already out. The other point, you can say, I will tell the client that I will assist her to deliver the placenta by applying the controlled cord traction to promote cooperation and allay anxiety. Then apart from that point, the other point, you can say, I will tell the client to inform me when the uterine contraction start in order for me to apply the controlled cord traction. So remember, when you're delivering the placenta, you need to put the placenta using controlled cord traction as you feel the contractions, as this will promote a smooth delivery of the placenta. The other point, of course, you can say, I will allow the client to ask you questions concerning the delivery of the placenta and correct any misconception. So as usual, let the client ask, and if there's anything that they need to be clear of, you need to give them the full information so that you clear out any misconceptions that they may be having. The last point, among other points that you can add here, you can say, I'll ask the client how the placenta should be disposed in order to respect the cultural needs, as the client may decide to have her placenta disposed of at home. So again, you need to find out from the client. Remember, there are certain cultural aspects where certain cultures, they will need to eat the placenta together with the family, just to fulfill their cultural aspect, except this is not advisable because it may promote spread of infection, especially if this child has any infection. Remember, certain infections can cross the placenta and affect the child, and then the effects or the microorganisms may still remain on the placenta. So if this is eaten by the family, it means that that particular infection may end up spreading to other members of the family. So again, there are certain other cultural aspects where the placenta needs to be buried at home. So you need to ask the client what you should do to the placenta, whether you should throw it or dispose it off. But whatever the case, you need to tell the client to say, if they need it back, you are going to decontaminate the placenta in 0.5% chlorine for about 10 minutes and then give it back to them. Then apart from that, the next heading that you need to have The next heading that you need to have is preparation for delivery of the placenta. So on this particular heading, you can say, I will put the client in a dorsal position for easy delivery of the placenta. Then the other point you can say, I will put the receiver near the vulva for easy recipient or receiving of the placenta. So the placenta, the receiver rather should be in between the thighs, in simple terms, of the client, so that immediately you're able to drop the placenta in the receiver. Then apart from that, you can say, I will give oxytocin. On average, you can say maybe 10 to 20 international units in the second stage of labor to promote uterine contraction that will aid in the delivery of the placenta and also to promote control of hemorrhage. So those are some of the points that you need to have on this particular heading. So the other heading that we can now have is delivery of the placenta. So on this particular heading now, this is where the actual job is happening from. Remember, third stage of labor, the main thing that we are talking about is to deliver the placenta. But we can't just talk about delivery of the placenta alone, minus other things that accompany delivery of the placenta. You remember, you need to gather all the marks, about 50 marks. So on this particular heading, the first point you can say, I will support the uterus using my left hand or my less dominant hand, in other words, to prevent uterine prolapse. Then the other point you can say, I will use my right hand or my dominant hand to grasp the forceps that is clamped to the umbilical cord for easy controlled cord traction. The third point on this particular heading, you can say, I'll apply controlled cord traction when the client complains of uterine contractions in order to expel the placenta. And apart from that, the other point here, you can also say, as soon as the placenta appears on the vulva, I will hold it with both hands in order to rotate it and to rope up the membranes for complete delivery. Then the last point, among others, you can say, I will put the placenta on the receiver for examination of the placenta and measure the estimated blood loss. So these points on this particular heading, they need to come out for you to get the 4 marks that you need. From there, the next heading that you can have is massaging of the uterus. So on this particular heading, you can have points such as, I will massage the uterus in order to expel the blood clots that may cause postpartum hemorrhage. Remember, when the placenta is out, we don't just leave the woman there. You need to massage so that all the blood clots come out, or as much blood clots can come out. And this will reduce the chances of this woman experiencing bleeding after third stage of labor. Then apart from that, the other point you can say, I'll feel for uterus contraction, which may be evidence of hard ballotable, as non-contracted uterus may cause PPH. So apart from that, in terms of this particular point, you'll find that if the uterus, once you feel for uterus contraction, this may indicate that there's no rescinding of any contraction that may go back up, of any clots rather that may remain in the uterus. And this may also indicate that if for example, if the uterus is not contracting, it may cause PPH, because when the uterus contracts, it also causes blockage of the blood vessels that supply the uterus, and this causes or reduces bleeding. So what you need to feel is to ensure that the uterus has contracted. And if it has contracted, this is a good positive sign. It means that the blood vessels are blocked where the maternal site had detached from, and this reduces bleeding after delivery of the placenta. Apart from that, the other point you can say, I will inspect the birth canal for any presence of active bleeding, which can indicate PPH. Then the last point, among others, you can say, I will check for any presence of lacerations or tears in order for them to be repaired, as they may cause or they may lead to bleeding. Then apart from that, the other heading that you can talk about is hygiene. So hygiene, remember hygiene in this particular case is performed so that we also prevent infections. So on hygiene, the first point here, you can say, I will clean the perineal area and remove any blood clots so as to promote comfort to the client. Then apart from that, you can say, I'll ask the client to put on a clean pad to prevent dripping of blood. Then the other point, you can say, I will encourage the client to put on a certain clean pant to prevent infections. Then you can also say, I will encourage the client to put on clean clothes for her own personal image or hygiene. So those are some of the points that you can have on hygiene. Remember, you can also talk about the patient performing sitz bath. Remember, sitz bath will also promote removal of clots and also cleanliness. And apart from that, you can also just perform frequent vulvar swabbing to promote hygiene and prevent infections. So these and among other points, you can still add them on this particular heading. Then apart from that, the last heading that you can have here is placenta examination. So in terms of placenta examination, here you can say, I will examine the placenta for any missing cotyledons or lobes or any placental abnormalities. And I'll also check for the health of the placenta and the weight in order to detect any deviations from normal. So here on placenta examination, you are trying to rule out any abnormalities. Remember, there are certain and a lot of other abnormalities that can be seen on the placenta. So when you are studying management of third stage of labor, also you need to read about abnormalities of the placenta. There are certain abnormalities which we call placenta circumvallata, where the membranes of the placenta, they immediately coil up the circumference of the placenta. That's an abnormality. There's an abnormality which we call placenta saxariata, where you find that there's a missing lobe which never developed on the maternal side, but it's developed somewhere in the uterus. And then you literally even see blood vessels going beyond the membranes of the placenta, meaning there's another lobe which was being supplied inside the uterus. And then there's another abnormality called placenta Bartoldo, where you find that the insertion of the umbilical cord is not centrally inserted or laterally inserted, but then the umbilical cord is inserted on the edge of the placenta, and that is termed as placenta Bartoldo. Then we have other abnormalities that we can, of course, still go on to talk about in terms of the abnormalities. So you need to read about those abnormalities of the placenta as well, and just have a clear understanding. So the first point, we are trying to say we are doing placenta examination so that we try to rule out as many abnormalities as possible. Then apart from that, the other point here, you can say I'll measure the blood loss to rule out postpartum hemorrhage. Yeah, this is very cardinal, because if you find that the estimated blood loss is going beyond 500 mils, this may indicate that this woman has gone into PPH, and you need to infuse a lot of fluids and blood very fast, because remember, the more blood this woman loses, the more effect it has on the circulatory system, and this can cause death easily. The last point, you can say, I'll measure the length of the cord to rule out long cord or short cord complications, short cord abnormalities rather. So you need to measure those things as well. And then apart from that, you just need to ensure that you need to ensure that you also measure just the circumference as well as the height of the maternal site. And this will just, when you do this, it will just ensure that you have a normal placenta, because of course the normal average circumference should be about 16, less than 16 or 12 to 16 centimeters. And then when we talk of the thickness or the height, we are talking of about 2 to 4 centimeters or so. So because the placenta, which has a maternal site which is also very thick, may indicate macrosomia. Babies, especially babies from born from diabetic mothers, and you find that also the weight of the placenta may be too much, maybe exceeding 500 grams. But all in all, these are some of the points that you can have on placenta examination. So in terms of the outline for management of third stage of labor, this is the outline that you need to have, and talk about all those points. So for today's session, this is where we'll end, and then next time we'll move on and look at other conditions for midwifery. Maybe we may look at preeclampsia as well as eclampsia as well. These are common conditions which come in IRH. Okay, so for today, this is where we are going to end. Till next time, we'll look at other conditions next time. Goodbye.